Good evening, everybody, and welcome, and thanks for joining. And nice to see that so many of you are here, and that you've all arrived in good time for a 7 o'clock start. I'm Louise Gatley. For those of you that don't know me, I'm the Chief Officer of Bolton LPC, and I'm joined with Alison Scowcroft, who is here today with a Meds Optimisation Lead for Midlands and Lancs CSU, and with Anna Muscolino, who's one of the senior cure nurse at the Bolton Hospital. A little bit about GM Healthcare Academy. So we are a group of partnership, I suppose, of NHS and community pharmacy, and we're supported by some of our key education providers such as CPPE. And we focus really on engaging and supporting community pharmacy to achieve full potential in service delivery. And doing that, we run an extensive range of training events. We have quite a comprehensive website as well, if people haven't seen it. And we use the training to support the whole pharmacy team, not just pharmacists. And there we are, that's our founding members. So it was the Health and Social Care Partnership, now GMIC, our LPN, both of the Greater Manchester LPCs, and CPGM Healthcare, which is our provider company. A little bit of Teams housekeeping. So please keep yourselves on mute if you're not talking to us. We will have a Q&A at the end, so feel free at that point to take yourselves off mute and have a chat. Otherwise, you can pop any questions that you might have into the chat box as well, and we can pick those up either as we go along, or if not, we will pick them up at the end. Tonight we're going to cover a little bit about the service implementation and how it works at a kind of national and regional level. And I'll then talk through the hospital end and what they're doing with the CURE programme in hospital. I'll talk a little bit about service delivery and a little bit about a comparison of the hospital service compared to the Bolton Council one. And finally, at the end, Alison will do us a quick demo of the PharmOutcomes modules that we'll be using. So I'll move on quickly over to Alison, who will pick up the first part of the presentation for us. Thanks.
Thanks very much, Lou. Next slide, please. Just going to give you a little bit of a background to the Nationally Commissioned Smoking Cessation Service around the long-term plan and the Ottawa model of smoking cessation. I'll tell you a little bit about the pilot, which we had locally in Greater Manchester, which was fantastic in Oldham, and give you an update on where we're up to with the national implementation. Next slide, please. So everybody should be aware of the NHS long-term plan. Prevention is a core component of that plan, and the long-term plan commitments set out the NHS's contribution to tackling tobacco dependence. Oh, sorry, could we just go back a slide? Thank you. So NHS long-term plan states that by the year 2023-24, all people who are admitted to hospital who smoke will be offered NHS-funded tobacco treatment services, and that is applicable not only to acute trusts, but also to maternity trusts and mental health services. So these long-term plan commitments are designed to be the NHS's contribution to helping to deliver a smoke-free generation, and they build on the good work that's already being delivered and are intended to complement the current stop smoking services. As you can see, there's a focus on both physical and mental health services, and the long-term plan gives a level of national direction, but with local development and delivery. Next slide, please. So we know that smoking cessation programmes already exist in community settings across Greater Manchester and across the North West, but they are variable in their involvement of pharmacy. So what the long-term plan is encouraging hospitals to do is to adopt the Ottawa model of smoking cessation, and this is going to be adopted throughout England through the long-term plan. It's a 12-week programme, and it specifically requires follow-up smoking cessation treatment with patients after they've been discharged from hospital. The Ottawa model of smoking cessation has been shown to increase the one-year quit rates by 11%. And the Royal College of Physicians have worked out that when this is implemented across England, it's expected to save the NHS around £85 million within 1 year. So there's some really powerful incentives for this service to be a success. Next slide, please. So the aim of the NHS Smoking Cessation Service is to support the delivery of the prevention ambitions in the NHS long-term plan. and more importantly, for community pharmacy to become a nationally available choice for patients to access smoking cessation support post-discharge. Next slide, please. So, as I mentioned previously, there were a couple of pilots for the Smoking Cessation Service which took place back in 2020 and 21, and we were really fortunate in Greater Manchester to have one of those pilot sites where Anna's colleagues over at the Royal Bolton Hospital sent referrals to patients, to pharmacies in the Oldham area. That pilot service was started back in October 2020, so kind of in the middle of the pandemic. We selected some pharmacies in Oldham following an expression of interest process to give good geographical coverage and extended opening hours. A second pilot area went live in November 2021 in the Lambeth and Southern boroughs of London, working with Guy's and St Thomas and King's College London. And all of those pilot sites have now transitioned into the Nationally Commissioned Smoking Cessation Service. Next slide, please. So just to give you a little bit of data, this is from the Oldham pilot. In that period of just over a year, from October 2020 to December 2021, just over 200 patients were referred to community pharmacies, and around about 40% of those patients were subsequently engaged with the service and enrolled into the service with community pharmacy. That's a rate of about 40%, which was in line with what we were expecting to see given our understanding of referral rates into the community stop smoking service. The four-week quit rate, sorry, it's a bit of a mouthful, that one. The 4-week quit rate was 57%. So of those 81 registered patients, 46 went on to achieve a 4-week quit, and a further 19 patients went on to achieve a 12-week quit. So those statistics were in line with the kind of figures that we were expecting to see from the locally commissioned stop smoking service. So just validating really that the community pharmacy service delivers the results that are expected. Next slide, please. So work commenced then to transition that pilot service into the Nationally Commissioned Service. So the CSU and NHS England work together with the National Centre for Smoking Cessation and Training, NCSCT, to produce a standard treatment programme which is bespoke specifically for the Smoking Cessation Service. PSNC and NHS England work together to negotiate and agree the consultation fees as part of the community pharmacy contractual framework, and also to agree the NRT costs which will be charged back to the ICB. The actual service specification was agreed, and then there was an intentional soft launch of the service to align with National No Smoking Day back in March this year. So registrations opened on the 1st of March for community pharmacies to register to provide the service. Next slide, please. So the Midlands and Lancashire CSU has been commissioned by NHS England to support the national implementation of the Smoking Cessation Service. So there's a small team of us, and we each have a region of the country to look after. And I'm the lead for the North West, so covering Greater Manchester, Lancashire and South Cumbria and Cheshire and Mersey. So the role of the CSUs is initially around scoping and mapping, so understanding the position of each acute trust in terms of their delivery of the relevant parts of the long-term plan, and getting their tobacco dependence teams in place, and then identifying key stakeholders within the area to support working groups being set up. Our role then is to facilitate implementation at a local level. As I mentioned, there's a CSU advisor available for each region, and also supporting those pilot sites to transition successfully, and then engaging with those early implementers and those sites who are looking to start delivery imminently, which in Greater Manchester is Bolton, which will be the second trust to go live with the service, following Oldham, who were the first due to being involved in the pilot. Next slide, please. So this slide just shows a bit of an overview of what the CSU is working on with lots of trusts around the country, and myself working with trusts across the North West. So the first stage is that scoping and mapping, engagement of stakeholders and establishing the working groups. Then once we've got the key people around the table, we look at agreeing the pathway. So what mechanism is going to be used to send those referrals from the trust out to the community pharmacy. Then we go into community pharmacy engagement, so the LPCs are involved throughout the process, but once we've got that IT pathway in place, then coming out to community pharmacists to engage, inform them what's happening locally with the service, and recruit pharmacists to deliver the service as appropriate, which is why we're here this evening. Next slide, please. Just a bit of an overview of the pathway. It's a very simple slide, this one, but initially you've got your hospital inpatient who's undertaking a supported quit attempt by Anna and her colleagues at Bolton FT. And then on discharge, there's a conversation with the patient to ask them would they like to continue to quit their quit attempt after they've been discharged. If they agree, they can be referred to the locally commissioned service if there is one available. In Bolton, unfortunately, that's not the case, so that's not an option for us in Bolton. Or they can refer to the community pharmacy using the SCS service, or the patient might decide that actually they want to continue with self-care, so there's no transfer of care on discharge. Next slide, please. To give you an overview of the model of care, this is in the service specification. So if you've read through the spec and you're familiar with it, hopefully you've seen this before. So the red boxes at the top is the hospital team who've identified an inpatient as a smoker and have initiated some support, behavioural support and NRT with that patient whilst they're in hospital. Blue boxes around the middle is the transfer of care. So the patient agreeing to continue with their quit attempt post-discharge and designating a pharmacy that they want to be referred to, a participating pharmacy. So upon discharge, that referral is sent through to the pharmacy via PharmOutcomes. Contact is then made by the pharmacist to the patient within that defined post-discharge period, which is 5 days. And then the green boxes is where the patient fully transitions into the smoking cessation programme that's provided by your pharmacy. So you take them through then up to 12 weeks. And post-event messaging is in place to ensure that the trust and the patient's GP are kept informed of that patient's progress throughout their quit attempt. Next slide, please. So we just pulled out a few bits that are relevant from the service specification and points for you to think about from a community pharmacy perspective. So this service is intended to complement your existing locally commissioned stop smoking services. I think Lou will cover that in a little bit more detail in the next section. Under the SCS, you can only see patients who have been referred from the NHS Acute Trust and who wish to initiate or continue their quit attempt post-discharge. You must make contact with the patient within 5 days of referral. That's really important. It's 5 working days from referral, and you must make at least 3 attempts to make contact with the patient. If you're not able to contact the patient, then you must reject the referral in PharmOutcomes. That message then goes back to the trust so that they're aware that you haven't been able to make contact with the patient. You'll provide support up to 12 weeks, but that includes the time that they were an inpatient. So if they quit smoking whilst they were in hospital and they were in hospital for a week, you will provide support for another 11 weeks to take them up to the full 12 weeks. You can deliver your consultations either weekly or fortnightly, as is appropriate for yourself and the patient, but the consultations shouldn't be more than 2 weeks apart. You're going to supply their NRT products at a maximum of 2 weeks at a time as well, and there is an agreed list of products in the drug tariff that you can supply, so make sure that you're checking that list, otherwise you potentially may not get reimbursed if you supply something that's not on the drug tariff list. Next slide, please. You need to make a clinical record of all service activity. The service specification states in Greater Manchester and in Bolton we are using PharmOutcomes, so that will be the clinical record that you make will be in PharmOutcomes, and we'll have a quick demo of the modules later on this evening. You need to use CO monitoring for any face-to-face consultations that you deliver, and you need to make sure that you've got the right equipment in place that fits with the service specification. There's no charge to patients even if they pay for their prescriptions, so you're not required to deduct any prescription charges. For example, if a patient does pay for their prescriptions, the NRT is to be provided free of charge. And you do need to return patient level outcome data to the referring NHS trust and to the patient's GP. Have a look in the service specification and make sure you're familiar with what it is that you require to send back. Because the PharmOutcomes modules that we're using, which I'll talk about a little bit later on, are a temporary version, we haven't got notifications and reporting and things like that set up for to help you with that. So you do still need to check the service specification and make sure that you're making those notifications manually. In terms of fees, if you signed up for the service with the BSA, then you'll have received a £1,000 setup fee. And then for each initial consultation that you deliver, there's a fee of £30. Your interim consultations, which are weekly or fortnightly, are £10. And then the last consultation that you complete with the patient is £40. And this one can be any time from week 4 to week 12. So it's the last consultation that you deliver with the patient. Next slide, please. In terms of training, if you've registered with the BSA already, then you should have completed all this training, because part of your BSA registration is you stating that you're ready to provide the service. But just to refresh you then, the pharmacists in your pharmacy should have completed the NCSCT Stop Smoking Practitioner Certification. If you've already completed that as part of your delivery of the locally commissioned service, then you don't need to repeat it. There's also some specialist NCSCT e-learning modules that you need to complete as part of this service. So one around supporting treatment for people with a mental health condition and pregnant women. And there's also an NCSCT module on using e-cigarettes, which needs to be completed. You also need to read the NCSCT standard treatment programme that I mentioned previously, and really familiarise yourself with the information that's in that standard treatment programme, because you're going to use that to support the consultations that you deliver with your patients. You also need to have the correct carbon monoxide monitor and an SOP, standard operating procedure, in place. Next slide, please. Just a little bit of an update in your area. So you can see there that Royal Oldham is green. They were live back in 2022, and Bolton is almost green, soon to be at the end of this week, beginning of next week. We're also in conversations with Stockport and Manchester University Foundation Trust in terms of them also going live, and we're having early stage conversations with the other trusts across Greater Manchester. So making good progress across the city, which is fantastic. Next slide, please. It's probably not a very good slide, this one, but this is just a little screenshot of the pharmacies that are registered around the Bolton area. You can see in the middle there, it does say Bolton underneath all those little yellow blobs. So we've got a really good number of pharmacies registered to deliver the service, which is fantastic. Next slide, please. So as I mentioned, we've got Oldham Hospital live, Bolton Hospital due to go live end of September, so this week, next week. We're going to be using a local version of PharmOutcomes, so we're not going to have the full functionality, unfortunately, of the national version of the PharmOutcomes modules, but it will do everything that you need it to do in the interim, whilst the national PharmOutcomes modules are procured by the Greater Manchester team. As Lou mentioned, we've got Anna from the cure team at the hospital attending today, and Anna's going to tell you a little bit more about the hospital end of the service and how things work for her and her team. And after today, we just need to make sure we've got enough pharmacy sign-ups to cover the geography of Bolton. So when Anna and the team start to make referrals, we've got a good choice of pharmacies for patients to be referred to. Next slide, please. So that's it for me. I'm happy to take any questions that you might have towards the end. I think that would probably be easier. There's some links here for some useful information. Please do visit the PSNC page if you haven't been there before. There's lots of useful stuff on there. And you can also see the link to the dashboard if you're interested in looking at pharmacy sign-ups. The link to the standard treatment programme is there as well. Thank you very much. I'll hand over to Anna, I think is next.
Hi everyone, I'm Anna and I've started as a senior cure nurse at Bolton. So I'm just going to explain a bit about the cure project at Bolton and just a bit about the patient journey and what we do there. Next slide, please. So CURE stands for Conversation, Understand, Replace, and Experts in Evidence-Based Treatment. So CURE is about changing the stigma and the culture. So in the past, smokers were told in a negative message, you've got to stop smoking. It's about your willpower. You've got to use your motivation. It's your fault if you fail. It's your choice that you're smoking. That nicotine is dangerous. It's a lifestyle choice, a behaviour change. It's someone else's role to help. However, the future message which CURE are going to portray is, so it's more positive. So we're going to explain it's a physical disease. It's about chemical dependence. That nicotine is harmless. We're going to give them treatments what work. And also just to show it's every clinician's role to treat tobacco addiction. Next slide, please. Alison did cover a bit about the Ottawa model, but basically it just showed the effectiveness of hospital-initiated smoking cessation. It was a systematic, comprehensive approach to clinical tobacco dependence treatment. And to conclude, the application of this system, there were increased rates of the delivery of the smoking cessation and more patients made further quit attempts after they were helped. Next slide, please. And aims of the CURE team at Royal Bolton Hospital. So we're going to identify smokers admitted to hospital, medicalise nicotine addiction for them, prompt the access to NRT and make sure it's at effective doses for them, provide expert advice and support the sick smokers and ensure that they remain motivated to quit, and improve the poor transition between secondary care and community smoking cessation services. Next slide, please. And the team at Royal Bolton Hospital will be me as a senior nurse. Then I've got 2 band 6s, Jennifer and Claire, and we're also getting 2 HIPs, which are brand new to the hospital, and it's going to be Tammy, John and Skirter. Next slide, please. So the process at Royal Bolton Hospital. So the nurse will commit the nursing admission, and we should automatically then get a referral to us if the patient smokes. Once we have got the referral, we'll go and see the patient on the ward, offering expert advice, offering treatment and starting them on the correct NRT. Obviously, the assessment length will depend on the acuity of the patient. We're also going to ensure that we book them for a 4 and 12-week follow-up, and our clinics are just going to be phone calls at the minute, and ensure that we ask them if they would like any further help and discharge, and that's when we're going to refer them via PharmOutcomes to pharmacies which offer smoking cessation in the community. Next slide, please. And that's it. At the minute, we're still a bit new, so we're still waiting to get our generic email address. Thank you.
Thanks, Anna. That's really helpful. I'm just going to cover now a little bit more about the Bolton end in community pharmacy. Probably recap on a couple of bits that Alison's already told you before handing over for the PharmOutcomes demo. So, like Alison mentioned before, it's always going to start this service with a referral from the hospital electronically. Patients won't be able to self-referring or walk through the door and say, I've been discharged from hospital, can I continue? There will always be a referral there at the pharmacy for you if a patient's been discharged under this service. Like Alison said, we're going to start off with a locally built PharmOutcomes template, and hopefully before long we'll be able to transition across to the national model, which uses the NYS integration, which I'm sure will be very welcome to us all when it comes to claiming at the month end. Alison has got available a summary document that shows you the kind of reports you need to pull to be able to collate all the correct information. So we'll send that on to you after the meeting tonight. One extra thing that we are asking you to do in Greater Manchester, just to provide a little bit of assurance to the GM team that you're ready to deliver, is that once you've registered on NYS, which I think a lot of you have done, but I think there are some pharmacies here tonight that haven't done yet, is that you complete the GM Microsoft form, and that's just collating that final assurance that you're ready to go and giving assurance to the GM team that you're ready. It's also going to collate details of the carbon monoxide monitor that you use in your pharmacy. So that's really important that you put the correct carbon monoxide monitor that's suitable for this service on there. I have noticed that a couple of pharmacies have registered the old models that you would have been given as part of the Bolton Council Service. and these are not currently suitable, or they're not suitable at all. So if you've done that and you know you've done that, please just fill that form in again with the correct information. So like Alison said before, we're going to be using this interim model, and it's a really great set of modules. The first bit is going to be the referral in from the trust. So we'll get that referral, it'll drop into your services tab in the same way that they would do if it was a GP CPCS or a DMS, and you've got your directly linked referral received to fill in that first bit of information. You've then got a couple of other modules available, your interim appointment templates, your 4 and 12 week quit attempt template. And I think as well, Alison might correct me on this when she comes back on, I think there may be a lost to follow up module as well to complete. This just summarises the IT pathway for you. Like we've said, our hospital is going to be working down the left-hand side there with the referrals via PharmOutcomes. Although you may, I suppose, as a service develops more across Greater Manchester, see other hospitals doing different things, but referring patients to you from hospitals outside of Bolton. So do be on the lookout for other ways that referrals might arrive in your pharmacy. Final slide for me, and these are just covering some of the differences between SCS and the Bolton Council Service. Been out doing some visits recently with Bolton Council, and we've been talking about this service quite a bit alongside the Bolton Council one, and there's a little bit of confusion there and people want some clarification on the differences. So I thought it'd just be useful just to summarise some of the key questions that we've been asked today, and some of it is just a bit of a duplicate and a recap on what Alison's already told you, but thought it would be helpful. So firstly, obviously the commissioning, we've got the nationally commissioned SCS and the locally commissioned Bolton Council Service. You don't have to provide both, you could provide one and not the other. It's entirely up to you which ones you decide to deliver in your pharmacy, but they are both available, and nationally advanced service, anybody can do that one, and Bolton Council, you know, are more than happy for as many pharmacies as possible to deliver their service to. Like we've said a few times now, patient access for the SCS is always via referral from the hospital, but Bolton Council, it can be a self-referral or it can be an identified in pharmacy patient. Smoking status wise, patients under the SCS will have probably already started their quit attempt. They almost certainly will have done and been provided with some products on discharge. But from a Bolton Council point of view, the patient must be a current smoker, and that must be a CO verified smoker as well. Under the SCS service, patients can be seen face-to-face or on the telephone. Either is acceptable, and that's become a bit more normal during the aftermath of COVID. But Bolton Council are now back to face-to-face appointments for their service. Staff-wise, up until this week, it was trained pharmacists only, but now we've added registered techs into that mix as well. So pharmacists, registered techs can deliver SCS, but not our normal trained community pharmacy staff. They can only deliver the Bolton Council service at this time. Alison has detailed the training for SCS. So I won't recap on that at all, but from a Bolton Council point of view, you must be an NCSCT practitioner, and you must attend any local updates when they're made available. We haven't got anything planned at the moment. There's been nothing throughout COVID. So if you've not had a local update or not attended one, don't worry about that. You can still continue to deliver the service if you're commissioned to do it. The SCS service allows 2 products to be provided. We know that 2 products is the gold standard. It certainly gives a much better quit rate with patients. Unfortunately, Bolton Council will only fund 1 product at the moment. So if a patient on the Bolton Council service requires 2 products, they must purchase the second one. And finally, another message about the CO monitors. The SCS service is quite specific around the monitor that you must use. I think there's 4 options on the PSNC website that you can choose from. And these, as well as doing a normal CO reading, they also do the pregnant women readings and adolescents too. So really important if you deliver the SCS service that you have the correct monitor. And the Bolton Council monitors that have been provided to you probably some years ago are not suitable for the SCS service, so you will need to purchase a new one if you've not already done so. Bolton Council allow you to use any monitor. It's used more as a visual aid, so patients can see those numbers coming down. They're not specific about which monitor you use, but obviously I think most of you have had free monitors provided to you at some point. I think that is it for me, and I'll pass you back to Alison now, who's going to do the PharmOutcomes demo. So if I stop screen sharing, Alison, is that okay?
Yeah, thank you very much.
And
let's hope this all works smoothly. Is that sharing okay?
Yeah, can see that fine.
Brilliant. So the first point that you will see the referral coming through is it'll drop down, as Lou said, into the services tab in the way that you see other referrals from GP CPCS or DMS, for example. You click into that referral and you'll see the standard form. It should be very similar to other referral services that you see. So all the information that's in there is what Anna and her team will have input at the trust end. You then have the options to either complete now, accept or return. Because you've got that 5-day window to make contact with the patient, what I recommend you do is you press accept. That tells everybody that you've seen the referral and you're doing something with it. So you're going to press accept and then make contact with the patient and book them in for an appointment, or complete that first registration and first appointment when you speak to them, dependent upon the circumstances. So always press accept, and then we know that you've seen that referral and you're doing something with it. At the point at which you're ready to complete that first consultation with the patient, then you're going to press complete now, and that will take you into the module. If you press return, that means you're rejecting the referral, and that a notification is sent back to the trust to inform them that you have rejected that referral. It will ask you to put some notes in as to the reason why you've rejected the referral. The only reason that you should really reject a referral is if they've been uncontactable within that 5-day period after the referral being sent, or if you've contacted the patient and they've declined the service, so they've changed their minds and they don't want to continue with your support for their quit attempt. There is something in the service specification around other pharmacies, but unfortunately this version of the PharmOutcomes module doesn't allow you to refer to another pharmacy. So your options are to accept, to state that you have accepted the referral and are making contact with the patient, complete now, or reject if that patient's uncontactable. So when you press complete now, then it takes you into the PharmOutcomes template. So you do need to re-enter the patient demographic information in again, even though it's up here, because that's just the way PharmOutcomes works, unfortunately. You need to make sure that the patient consents to data sharing, so read out the information to them, and it won't let you continue unless you press yes for consent to share. These boxes are just around supporting the NHS digital return, so you just have to tick that it's a pharmacy setting and a one-to-one, and then record whether you're seeing the patient face-to-face or remote. There's then a lookup list to record the patient's GP, and some information just to collect around how the patient wants to be contacted. If you select a phone or SMS, then it asks you to fill in the details there, so you've got that record. It does ask a question about levy status, even though it's not relevant, just to record what the patient's status is. And then there's a question around occupation status and any mental health conditions that the patient may have, just for purposes of reporting. We're also recording the reason for choosing the pharmacy, just because it's useful and interesting data for us to have. We're then going to get into the details of that patient's quit attempt, so understanding what their quit reasons are. And there's a little calculator there for you to calculate their Fagerstrom score. So if you click on the calculator, then it brings up the options for you to answer, and then it calculates the score for you. So we've got a Fagerstrom of 3 there. It then prompts you to discuss any previous quit attempts. So you can discuss those with the patient in terms of any triggers or helpful information that might support them this time. You've got a list of information around discussing with the patient their readiness to quit and the treatment programme, etc. And you've got a link here to the standard treatment programme that I mentioned earlier, which should be used to guide the consultation. You're then going to record their CO status. So if you're doing a face-to-face consultation, then you can use the CO monitor to support this, or if not, if it's a face-to-face, then you're going to be self-declared not smoking or smoker. Enter the quit date in here. So if they've continued with their quit attempt since they were discharged, then the quit date will be the date they quit smoking whilst they were in hospital. If they have started smoking again since discharge, but they're still motivated to quit again, then you can agree a new quit date with them at that point, and their 12-week support will start from that quit date. Just record which week they're in terms of their quit attempt, depending upon that previous discussion, and you're then going to go into your NRT supply. We're all aware, I'm sure, that varenicline Champix is not currently available. So if there are patients who have heard of that and are interested, then you're going to need to counsel them on the effective and appropriate use of combination NRT as an alternative. It does list bupropion or Zyban as an option. If the patient does want to quit using bupropion, then they do need to get access to that through their GP. So they will need to make an appointment with their GP to discuss that. You can still provide that behavioural support alongside the bupropion if the GP is prepared to prescribe. Likewise, you can also provide behavioural support if somebody wishes to quit using a vaping device, but they do have to provide and pay for that device themselves. There isn't any provision for supply of that product through the service. Just a quick question to check whether they're continuing with the therapy that was initiated in hospital. It is within your gift to make changes if the patient agrees. If they've maybe not had a great time with something that was initiated in hospital, you can try something different with them. So that's a conversation with the patient around how they've got on with their therapy. We've then just got a little bit of guidance here, which is based on nice guidance in 2021 around the combination products being most effective, as Louise mentioned earlier. So you can then record the products that you've supplied. And there's a link here to the drug tariff online, so you can check the products that are available. We've got a free type box for any consultation notes that you want to add to support that. Please don't add any patient identifiable data in that free type box. And then just agree the next appointment time and date with the patient and record that in here, and the pharmacist name and GPHC number. So that's your initial consultation. Then you're going to agree, and this, sorry that when the screen comes up now, there's lots of messy things on here, you won't see them all. Once you've agreed your duration or frequency of appointments with the patient, you're going to see them probably weekly or fortnightly. The next one that you're going to go into is the interim stop smoking consultation. So this is to record all of your consultations with patients that are not the initial one, week 4 or week 12. So any other consultations that you have that are not initial week 4 or week 12. It will look up the client's name back to that previous registration that you made, and you've got the same consent to participate. And then you're going to go through a very similar set of questions where you're recording the week in the quit attempt, asking whether the patient is abstinent or not, because clearly you're a bit further along here in the progress. We've got another link to the standard treatment programme there, and a few bits on the side here that talks to you about the types of things that you should be talking about with the patient in your interim consultations. You're going to record their CO status again, and then same questions come up around product supply, recording your NRT, and then the same again to add any notes that are relevant to the consultation, the name, GPHC number, and the date of the next appointment. When you get to the 4-week point, then you do need to use a different template to record that 4-week quit outcome. And that's because at some point in the future, when this is all linked up and working magically, that will trigger a notification to the trust to say what the patient's status is at 4 weeks. So you need to record whether you're doing a 4 or a 12-week quit. And then you should see that the questions are very similar as in the other modules around product choice, NRT supplied, and any notes that you add. So 4 and 12 weeks, you need to make sure you're using the 4 and 12-week quit outcome appointment. There is a 4th module, which is loss to follow up. It's a very simple one for you just to record that the patient did not attend an appointment and to add some details in there, either any contact attempts that you've made or if you've managed to contact the patient and they've declined to continue with the service. I'm not sure whether this is a feature of the Farm Outcomes modules that are commissioned nationally or not. It may not be, but it's something from the Royal Bolton Hospital perspective that we felt was important to add in. So just a very brief letting us know, just so we can close the loop in the data if the patient doesn't attend. So that's the total of the Farm Outcomes modules. As Lou said, these are not linked to any funding. So quite a lot, often with a lot of services, Farm Outcomes generates an invoice, doesn't it, which gets sent to the commissioner, and then the money magically appears in your bank accounts a few weeks later. Unfortunately, with this one, that's not the case. So there is some information that Lou will send out to you around how you can generate a report in Farm Outcomes, which will give you the information that you need to fill in your manual claim. So there's a spreadsheet that you need to complete and submit to the BSA on a monthly basis. I think it's by the 5th of the month. So Lou will send that information out for you. And as I mentioned before, the notifications to the trust are also need to be done manually. So that you will accept or reject the referral at the very beginning of the process, and the trust will see that notification. But after that point, the other notifications that are required in the service spec you will need to do manually. So that's 4 and 12-week quit. And there's a template in the back of the service specification that you can use to help you with those notifications. So I'll stop sharing my screen and back to you, Lou.
Brilliant, thanks Alison. As a bit of a whistle-stop tour of it all, and thanks Anna as well. If we've got any questions in chat, let me have a quick look and see if there's anything there. We haven't got anything, so if any of you've got any questions now, it would be great if you had to pop them into the chat if you don't want to speak to us. But we're more than happy for you to show your faces and have a chat. So has anybody got any questions at all? Either, you know, raise your hands or type it in chat and we'll be happy to pick them up now. Anna's got a hand up.
Sorry, it might be a silly question, but so do you know when we refer to you, do we kind of transfer the care? So would we not book them then for the 4-week and 12-week appointment?
So it's up to you, Anna. Some trust tobacco dependence teams are doing those 4 and 12-week follow-up themselves in addition to what the pharmacy is doing.
So yeah,
we can do that. If that's part of your process, then you can do that in addition to what the pharmacy will do. The pharmacy will arrange their 4 and 12-week appointments in line with the sessions that they've agreed with the patient. So if you're booking those in advance and everything goes to plan, they should line up. If the patient has a lapse and may start smoking again after discharge, but do engage with the pharmacy, it might be that those 4 and 12-week quit dates that you've arranged don't quite line up. That would be the only issue of booking those in advance. But I know that some trust teams do still do those follow-ups themselves because it's part of your data reporting requirements,
so I thought
isn't it?
we have to report that data. So that's good. Also, so if say we booked a 4-week appointment and when they were an inpatient they didn't want to be referred to pharmacy, could we still refer them at our 4-week appointment through Farm Outcomes to pharmacy?
I'm not sure about that. I'd have to check what the service specification states around the timing of the referral. I don't think it's explicit, but it does certainly talk about referral at discharge. So if you needed to refer them at a later point, I'm not sure, Anna. Well, maybe I'll have a check at the service spec and take that one offline if that's okay.
Yeah, that's fine. Also, sorry for all these questions. Can we have an up-to-date list of all the pharmacies in Bolton that do offer the smoking cessation? You know, just so we got their contact details.
So I do need to arrange some time with you, Anna, to show you your end of the Farm Outcomes modules. When you see those and you go in, you'll have one section where you register the patient, but then when you actually make the referral, it links directly to the pharmacies that are registered. So you'll only be able to choose a pharmacy that's registered, and it actually gives you a little map, so with little drop pinpoints on it. So I'll talk that through with you in the next couple of days, and then you can see how that works.
Yeah, and then sorry, last question. Will our team at the hospital be able to see what the pharmacists have kind of done with the patient through Farm Outcomes, or will it have to be sent separately?
You'll be able to see the status of the referral, so you'll be able to see whether it's been accepted, completed or rejected. that's about all you'll see.
Okay.
In terms of the other bits, then
Yeah.
that data sits in the pharmacy end of PharmOutcomes.
Right.
Lou might be able to support with some access to data because Lou's got access to the GM license. So if there is some extra stuff, then Lou from the LPC might be able to help with sending you some reports just whilst we're in these having to use these temporary modules.
Okay. Thank you. Thanks so much.
Yeah, happy to do that. Happy to help with whatever data I've got access to that you might find useful, so we can talk about that and have a look at it maybe once we started sending some referrals through. And equally, if you want a paper list of the pharmacies that are signed up as well, if that's helpful to you, we do map it to the PCNs as well, so you'll be able to have that.
That'd be helpful.
If you just find it happy, just have a have a paper copy, we can do that.
Yeah.
There's a couple of questions in chat, Alison, from Gullum. The first one is, would patients that have quit using vapes be eligible for the service if they want to quit vaping using NRT?
Oh, that's an interesting question. So I did read it to start with and thought, yeah, actually that's fine, because you can give the behavioural support if they're wanting to use the vape. But actually the question is, do they want to quit vaping using NRT? I don't think it's that explicit in the service specification. I think if Anna and her team have identified that that patient is a current smoker and they want to quit using NRT, the spec doesn't clarify that that patient needs to be a current smoker of a cigarette. So I guess maybe that might be a question back to Anna to say, when you're identifying an inpatient as a smoker, does that include them smoking? Does that include them using vapes? Would that count as them being a current smoker?
I think at the minute our referrals are generated only if they're a smoker and they're a smoker and a vapor, not just if they vape.
Okay. So it may be that we don't get patients referred through because they're not triggered that way in terms of the cure team in the hospital.
Yeah.
But good question, Gullum. I've not had that one before.
The next question is, does PharmOutcomes allow sending SMS messages to patients? I don't think it does it?
No,
but
you can set that up with certain PharmOutcomes modules, but I haven't done it for these just because they are like a temporary set of modules. I'm not sure whether the nationally available modules will have text messaging as a functionality either. I think the challenge with text messaging is you can tie it to today's appointment, but you can't tie it to the appointment in 2 weeks' time. So if it would depend on if you were doing weekly or fortnightly appointments, you have to set the text message to happen a certain period of time from today's appointment. So it wouldn't necessarily work for a service where you're doing weekly and fortnightly, because your text message would be too early if it was a fortnightly appointment, if that makes sense. But it's not something that I've explored with PharmOutcomes for this particular set of templates, sorry.
If we've got any more questions from anybody, any hands up, anybody wants to talk to us, or anybody want to put anything else into the chat? It's very quiet tonight. Nothing else.
I would take that as us having delivered a very comprehensive session, Lou. We've covered absolutely everything because there's no more questions.
Nothing that we don't know. No, so thank you very much, everybody, for joining us.